Good morning, everyone, and thank you for joining us. Welcome to BCIRPU's 2021 webinar series. Today, our speaker is Dr. Takuro Ishikawa. Dr. Takuro Ishikawa is a senior scientist with the BC Behavioural Insights Group. He combines his expertise in behavioral insights and epidemiology and develops interventions to reduce health inequalities, improve risk communication, and change individual health behavior. Before he joined the BC Public Service, Dr. Ishikawa worked as a researcher at the BC Children's Hospital Research Institute, the Colombian government, the Inter-American Development Bank, and the United Nations Development Plan. Dr. Ishikawa has a PhD in experimental medicine from the University of British Columbia, and he is a CIHR Fellow in Population Interventions for Chronic Disease Prevention and a UBC Public Scholar alumni. Today, we will be discussing what behavioral insights are, what health stereotypes are, stereotypes around booster seats, and how to diffuse these stereotypes. After the presentation, you may unmute your audio line to ask questions, or we will monitor the chat box for questions or any comments you may have. We are now ready for the presentation. Dr. Ishikawa, over to you when you are ready.
Thank you, Anita, and good morning, everyone. Thank you for joining us today. Yes, I just want to reiterate a little bit of what's going to be my presentation, and it's going to, but before we do anything else, I would like to start by acknowledging that I am joining this online meeting from the traditional unceded territories of the Coast Salish peoples, the Squamish, the Tsleil-Waututh, and the Musqueam nations. And if you can please put in your chat box the traditional territories from which you are joining, I would pretty much appreciate that as well. Before we continue, so just going to reiterate again the summary of what I'm going to be discussing. I'm just going to start talking about what behavioral insights are and the work that I'm currently doing with the BC Behavioral Insights group, because this is going to provide context on what is going to be the focus of this presentation, which is health stereotypes specifically, and more specifically, stereotypes around booster seats. So let's jump right in. What is this thing that we call behavioral insights? Let's begin with some kind of like a mental exercise. So imagine that you go to the supermarket, and you sometimes, when you have time, it's a weekend or it's a Sunday afternoon, you just had lunch, and then you go to a supermarket to buy some groceries for the rest of the week. Maybe your shopping cart will look something like this. You have pretty much everything that is in your shopping list and nothing that is not on your shopping list, right? You have time to go through your shopping list and very calmly and plan. You can plan. You can just go through the grocery and buy a number of items for the week. But if you are going to the grocery store on a Tuesday evening after work, you just pick up your child and you're rushing, your child is hungry and you want to go home, it's possible that your shopping cart looks more like this, right? So maybe you bought a couple of things that you didn't have planned in your list. Maybe more sugars or caffeine to energize your week, because you're thinking about rushing and perhaps not the healthiest choices that you might desire to purchase. And what this basically means to us is that our choices aren't always consistent, right? Sometimes those choices depend on how we feel that day. Those choices may depend also on a lot of environmental factors. One example of this is what is available at the moment where you're making the purchase. So if you think about what you find in the checkout alley while you're lining up to pay, this is what you normally see, right? Basically chocolate and candy. And in many cases, many of us maybe at some point will just yield to the temptation and end up buying some chocolate bar or some candy while we're waiting to pay. Interestingly, some behavioral researchers wonder what would happen if we switch all these items at the end or during the lineup while people wait for the cashier, and switch them for healthier food like fruits. And so they did a switch, and they measure how many items would be purchased if you just put fruits at the cashier. And sure enough, what they found is that simply by locating these items next to the moment of paying for your groceries will increase the consumption or the purchase of these healthier items. So only by changing the position or the location of the items, you can induce certain type of behavior. And that's basically the principle underlying behavioral insights. The way we think about this is that our choices are determined by what we call the choice architecture or the environment. And the choice architecture is almost never neutral. Anything that is set up around the moment when we make a decision or a choice, or the moment where we are enacting specific behavior, is going to influence how we're going to behave. The reason this happens is because we tend to operate with two different systems or cognitive systems. Our mind operates with two different ways of thinking. This is down to a now famous book by Daniel Kahneman talking about thinking fast and slow. That's the title of the book. Basically, the way we can understand this is by thinking about an analogy of a geeky, dorky sci-fi. As you can probably imagine, that's that kind of bit. That's me. So basically, what you have is that the same. If you're familiar with Star Trek, I hope you are. Captain Kirk and Mr. Spock basically are two very different types of individuals, right? So we have Captain Kirk and Spock who try to work together to steer the ship and to make decisions about what to do in those adventures. But they are very different types of individuals in terms of how they think and they make decisions. Captain Kirk represents what we call the System 1 that acts from the guts. It's instinctual, and this System 1 is effortless, fast, and often uses stereotypes to make decisions, and often is also based on meaning. System 2, on the other hand, is the person that, with the mind that is from the head, is logical, effortful, but also is slow. And also in terms of processing information, uses literal information, not necessarily interpretation and meaning. So the way these two systems interact determines in the end what decision we're going to be making. The thing is that most of the time, we adults rely on System 1 to make our decisions. Most of the time, our decisions are driven by the emotions or automatic reactions that we're not even aware of. Now, System 1 is critical because we have limitations in these cognitive processing abilities. So our attention is finite is finite, so we have limited resources for attention. So for everyday life decisions, we rely heavily on system one. So what this means is that we're not the highly rational decision makers that we think we are. Instead, we are prone to bias, or we can be easily swayed by how we feel at a given moment, by temptations, like when we just purchase that chocolate bar at the end of our shopping activity. And this explains why we might have sometimes difficulty following through, despite knowing what we need to do and despite our best intentions. So when we think about behavioral insights, sometimes the way we think about it is in terms of closing the intention-action gap, right? So we may have the best intentions to do things, like we decide those that make those decisions based on system two. System two tells us that is good for us to exercise. So that is good to us to save money, or that we should never text and drive. But a human, your human mind, and the fact that we have a system two and rely so much on it, basically gets in the way of our own intentions. And sometimes we just watch TV instead of exercising, or make impulsive purchases online instead of saving money, or read a text while driving because I'm just waiting for this important phone call and it's urgent and it's just this once occasion, not all the time. Or we can make any other type of rationalizations or excuses to do it, even though we know we shouldn't be doing it. So because we're not solely driven by system two, by logic, rational decisions and analysis of information, we often have these gaps between intentions and action. And this is mostly where the work of behavioral insights lies. Why should you care in people who are working in health promotion, public health? Well, the thing is that most of the decisions that people make are influenced by the policies and programs that we design. And if we are designing policies and programs, we're also designing the choice environments in which people are going to live and make decisions about their health, their finance, or their children, or their education. So in public health, we just sometimes make the mistake of assuming that people are always operating in system two, meaning that logic and rational way of thinking, right? So if we assume this when we develop a program to promote booster seat use or to promote healthier nutrition choices or to promote helmet use, then it's likely that those programs are not going to be as effective as they could be if we actually focus on system one. All these ideas that I am summarizing or cramming in a few slides are the result of decades of research in psychology and economics. And it's very reliable. It's based on theories that actually can predict behavior with a decent degree of accuracy. And they have become part of what we now know as behavioral insights. This is the Behavioral Insights Group. We are a corporate behavioral science consulting group housed in the PSA. That's me, and these are my colleagues who also help a lot in this presentation. But importantly, what also happens is that a few years ago, there was only like 5 or 6 behavioral insights groups or teams dedicated to do this work around the world. Nowadays, this field has exploded, and there are around 300 of these teams or units around the world using these 40 years of research to improve the health and the living conditions of populations. All these groups, including us and me, just to give you a little bit more context, basically work in terms of combining 3 different realms of areas of expertise. We combine understanding of real-world challenges, those faced by you, for example, in terms of public health problems. We use these rigorous research methods. We often try to use randomized controlled trials to test our interventions. But also we include in those developing of interventions this knowledge about people's choices and behavior. This knowledge stems from economics, psychology, sociology, and even anthropology. Most of the work that I do with my colleagues of the BC Behavioral Insights Group is can be described as what is now known as nudging. The idea that if we deploy very small, low-cost interventions, we can steer people's behavior just by changing the way a letter is written, or just by changing the way a cafeteria offers combos in the morning for students. Underlying all these principles is the idea that we can use these nudges, but only to close the gap between intention and action. And by that, I mean, we're not going to manipulate people into doing something that they don't want to do. We manipulate people, we just basically help them close the intention action gap. Okay, so this idea of nudging is one of the strategies that we use at Behavioral Insights Group. And essentially, what it means is that we're trying to develop an intervention that taps into the way the system one works. What is an example of these nudges? Here is a recent study published around the problem of COVID-19 vaccines, and trying to find ways to encourage people to make appointments and meet those appointments to get COVID-19 vaccine. So this study was conducted at the University of California, Los Angeles, and included 113,000 patients. And they basically, what they did was to try different formats or messaging and text to invite people to get an appointment to get a COVID-19 vaccine. So either with a simple text, this is your appointment is ready, or please make an appointment. Either what is called an ownership text, which is, for example, there is a vaccine available for you, you can claim it now by making an appointment. Or they try or compare that with a simple text with a video, right? Explaining COVID-19 vaccines, why they're useful. They also made another intervention combining ownership and video. And then they had a control group, which was basically a holder group. They received any of the interventions later. So what they found is that actually just by introducing this nudge, a little piece of text that emphasized your vaccine is waiting for you, claim it, come to the appointment and get your vaccine, they had a higher response and a higher number of appointments on average. So this is what a nudge basically looks like in order to encourage behavior. A tiny modification of a message set up in some type of what we call touch point, a place where individuals interact with our intervention. And the closer it is to the decision point, like if you receive a text and you can make an appointment immediately, for example, the better and the more effective it is. That is what a nudge is basically in short terms. Another alternative to nudging is what is called boosting. And this is going to be the focus of the rest of my presentation, because the work that I did on booster seats, funny enough, is reflected on the idea of boosting system one. So one thing is nudging system one, taking advantage of these shortcuts, heuristics, and irrational predictability of the way the system one operates. And another way is boosting system one. And by that, what I mean is that although often, even in the world of my colleagues and the community in behavioral insights, we think of system one as kind of dumb and easily swayed by emotion and maybe not as effective. Actually, there is more research coming out indicating that system one can be trained to be smarter, to make actually better decisions. So we don't even have to nudge it. We can just train it to make sure that whatever is the instinctual reaction or choice that a person makes could be more closer to what is the healthier choice or the wiser in terms of finances or in terms of education or child development. So this basically leads us back to the notion of health stereotypes. I previously mentioned that system one also kind of uses stereotypes because it's a quick way to make decisions and a quick way to basically make judgments about what is healthy or not healthy, right? So if we, for example, think about recent COVID vaccine concerns, COVID-19 vaccine concerns, people will be like, oh, but these vaccines are kind of new. This is a new technology, and new technology that's kind of scary. I maybe want to stick with traditional technologies or traditional vaccines. So this comes back to the idea of, oh, well, if it's unknown and strange, probably we should be cautious about it, even though maybe as a general rule, that's true, but in this particular case with COVID-19 vaccines is not the case. So that's kind of like the idea of a healthy stereotype. It's an overgeneralization of something that has a kernel of truth, but is not exactly a complete version or understanding of a particular health problem. So let's go to an example. One of the classic examples of a health stereotypes is the idea that sexually transmitted infections are fluid-borne diseases. And this obviously leads people to believe that, well, if condoms block fluids, because they're kind of often described as a barrier, then condoms prevent all STIs. So this is true. Like condoms, a lot of STIs are fluid-borne. And yes, condoms, because it's a barrier, prevent some STIs, but it's an incomplete understanding of the situation because some STIs are transmitted through the skin, like herpes simplex or HPV. So if someone associates or operates with the stereotype that STIs are fluid-borne, then that person is likely going to overestimate the protection afforded by condoms because it's going to forget or neglect the risk of skin-to-skin STI transmission. In the case of booster seats, there is, or that's like my proposition in my study, there is a stereotype, and the stereotype is what I call ejection stereotype. The idea is, and let's go like a step by step here. Let's talk about initially what is the purpose of a booster seat. So if you see it in these graphics, you see an adult wearing a seatbelt. And as you can see, the seatbelt is placed across the rib cage and across the pelvis. Because the seatbelt, the way it prevents injuries is by redirecting crash forces to stronger parts of the body, in this case, the rib cage and pelvis. A child needs a booster seat because it's usually, we're talking about children 4 to 8 years old on average, right, that are too old to be riding in a forward-facing seat. So a child needs a booster seat because it's not big enough make to wear the seatbelt where it should be, which is across the chest and hips. So if you see on the right, the situations of a child sitting in a car, not using a booster seat, the seatbelt either rests on the belly or across the neck, or when some parents will put the shoulder blade behind the child's back, or some parents will put it under the child's arm. But if you see all these other three images on the right, you will see that the seatbelt is actually placed on top of internal organs or across the neck. So if you understand that seatbelts prevent injuries by redirecting crash forces to or specific parts of the body, then is when you understand that actually having a child with a seatbelt without a booster seat is pretty dangerous, because it's going to redirect forces to internal organs, the spine, or the neck. And this is why booster seats are important, and this is why this is how seatbelts work. My proposition is that there is a stereotype or a misconception about how seatbelts work, because we tend to think of seatbelts as preventing ejection, not necessarily as redirecting crash forces, and that we need to promote, in order to correct this misconception, we need to promote the understanding, or the correct understanding, of how seatbelts work and how booster seats prevent injuries. So why I focused on booster seats? Because basically we know that booster seats are indeed, because of the way they work, indeed reduce the risk of injury. This is like the most recent study, which was conducted in Alberta, showing as a case control study with children 4 to 8 years of age who were injured. And basically shows is that the odds ratios for children who were wearing seatbelts of getting injured compared to children who were in booster seats was 1.21. So they were more likely to get injured if they were wearing seatbelts. And interestingly, but also makes a lot of sense, though the odds of serious injury for frontal crashes was 1.46, which also makes sense based on what I just mentioned in terms of how the seatbelt works. And this was published last week in the Accident Analysis and Prevention. So booster seats indeed are effective. The reason this is an important stereotype or important problem to tackle is the fact that booster seat use in Canada is still reportedly low. This map that I'm showing to you is using pretty old data, almost a decade old. I will show you more recent studies, which we're still behind in terms of getting more parents to restrain their kids in booster seats. So as you can see, what is interesting here as well is the fact that even in provinces where there is legislation mandating the use of booster seats in 2010, that the rates of booster seat use were still low. So for example, if you see Quebec, which is one of the oldest provinces with the oldest booster seat legislation, back in 2020, they had 25% rate of booster seat use. If we look at more recent data, yes, so there's a study that was published in the United States, looking at hospital records, and I found that almost 6% of children were not properly restrained. Mind you, this study kind of groups all car seats, so we don't really know exactly, but this 6% is is low. A more recent study that was conducted by the Child Passenger Safety Association of Canada found that 52% children are basically using seatbelts too early, meaning that they're not in booster seats, even though they should be. more recently, or less recently, there's a study in Alberta that showed like 77% use of booster seats. Mind you, this study basically used community events and basically roadside checks, so maybe there's a self-selection bias. But all this information basically in aggregate tells us is that, yeah, booster seats still is an issue that we need to tackle. And therefore, it's important to think about ways to promote or encourage booster seats, which is why the idea of this booster seat stereotype is important. So what I'm going to say is kind of describe the hypothesis that I have in terms of this healthy stereotype around booster seats. The idea is that, as I mentioned before, I suspect that, or suspected initially, that there is some tendency of people to think that injuries to passengers in vehicles are ejection related. So if you look at these 4 pictures, then you will see that, yeah, well, all these 4 ways of restraining a kid in a car prevent ejection. So seatbelts and booster seats, both of them prevent ejection. Therefore, seatbelts are enough to protect children riding in cars. And that's what I describe as a stereotype around booster seats. And I call it like the ejection stereotype. Lately, I've been rethinking that term. So my proposition is that this stereotype leads people to believe that all these 4 ways to restrain a child kind of provide roughly the same protection, and therefore, and that it kind of explains why parents still don't use booster seat, despite the fact that it's mandated in most provinces in Canada and in most states in the United States. So to test if if there is grounds to think that there is a stereotype around booster seats and seatbelts, I conducted one study. And in this particular case, basically, I interviewed or I surveyed child safety seat technicians. The reason I chose experts is because, well, one thing is to have a stereotype or a misconception, but one on a completely different thing is to just is to not know or not having the information. So in this particular case, I wanted people who have the information about how booster seats work and how seatbelts prevent injuries, and wanted to see if they still have this tendency of thinking injuries to passengers as ejection related. So this goes back to the idea of system 1 and system 2, right? For someone who is knowledgeable about this topic, about booster seats or car seats, that will be system 2 type of knowledge, logical, rational, technical. But then system 1, which operates with stereotypes and overgeneralizations, might still get in the way into making people think, oh yeah, right, ejection. So yeah, as long as it prevents ejection, we're okay. That was basically the idea. So I took 1,257 certified child safety technicians and I conducted a survey, and the questions were, more important questions of this survey are here. I predicted that if I showed a picture of this kid with a booster seat and asked the person, please tell me how much this setup, this arrangement of booster seat and seatbelt reduces the risk of injury. And in another part of the questionnaire, I asked him pretty much the same question, semantically identical, but instead I added, compared to seatbelts alone, the combination of seatbelt and booster seats used as shown in the picture is how much effective in reducing this risk of injury to the head, neck, spine, abdomen, internal organs, as well as injuries resulting from ejection. So this red part was kind of like a reminder that, remember, that protect the booster seats specifically help prevent injuries to neck, spine, abdomen, and internal organs, in addition to injuries resulting from ejection. So what I predicted is that people would provide a higher rate of risk reduction in the second phrasing of the question compared to the first one. The other key question in that survey was similar, but the picture was just a child wearing a seatbelt with the shoulder belt behind the back. Same red, the text in red, same additional text specifying the injuries that booster seat is meant to prevent. And what I predicted is that these experts, child safe technicians, would just make no difference, because obviously for a seatbelt alone, there's no difference in protection. So what did I find? I found that indeed, people's estimates of risk reduction afforded by booster seats were higher when I was using the second word, and this is the magenta line in this graph, compared to the first word. And the effect, as you can see, is not as big, but there's still an effect. And indeed, as I predicted too, we found that in the second, for the seatbelt case, estimates of risk reduction afforded by seatbelts, there was no difference. So just keep in mind that these are experts, so again, people who have the system 2 expertise, and I was trying to see if the system 1 responded in a stereotype way. So it looked like they do. So it looked like this stereotype exists and persists. We have a specific limitation in terms of the response rate to this survey, because a lot of people share it on Facebook and Gmail. So we couldn't keep track of how many people received the survey and how many people actually responded. So, but again, these are experts who have system 2 knowledge and still showed this difference between the answers, which is some indication that there is some stereotype or grounds to do a stereotype, or to conclude that there is such a thing as an injection stereotype. So I took those findings and then see, okay, the most important thing really is parents of children. I cannot do the same test on parents because they are lay people. So it would be hard to distinguish, do they provide different answers because they don't know, like their system 2 doesn't have the information, the formal scientific training on booster seats and car seats, or is it because there is actually a stereotype? In other words, whether or not they have the stereotype despite knowing. So because parents are lay people, I did not pursue this hypothesis of a stereotype. And instead, I jump into the idea of, can we improve parents' perceptions of booster seats and assessment and value of the safety, extra safety afforded by booster seats, if we explain to them how seatbelts work and how booster seats prevent injuries. So what I did was to devise an infographic to explain with the fewer words possible how seatbelts work, how seatbelts prevent injuries, and why booster seats are so important. So as you can see, probably the text is too small, but essentially is kind of using comic techniques of communicating graphically, showing a kid with a seatbelt and how the seatbelt will just focus crash forces to the neck and internal organs in case of a crash. Same in box number 2. Skip box 3, what ejection happens and how the booster seat actually works by explaining that it redirects crash forces to the ribcage and pelvis. So this is what parents would be seeing. And I tested this on a randomized control trial. It was online, double-blind, and using what we think is a 2-group parallel randomized control trial. In total, I had 731 parents of children 4 to 8 years old. And what I wanted to see is whether or not they increased their perceived benefit of booster seats in terms of how much risk reduction of booster seat affords. Basically, so I sent the invitation for parents. There was an initial assessment of what's the perception of the benefit of booster seats. Then I randomized parents to either the control. The control group basically received the standard online Transport Canada information on booster seats at the time. And the intervention group received that same Transport Canada information. And in addition, they were provided with this infographic that I just showed you. And then I follow up with the assessment. I'm kind of running a little bit of time, so I'm just going to go very quickly through this. What you can see here is two measurements that I took with the booster seat scale that was published by Beth Bruce and collaborators a few years ago. And as you can see, the group with the intervention, the perceived benefit of booster seats was almost twice as big or twice higher compared to the control group. So basically, they indeed increase the perceived benefit. And what you see in the second row of this table is the key benefit is basically their understanding of what are the types of injuries that booster seat helps prevent, injuries to internal organs and the spine. And it was almost twice as high compared to the control. And this difference is, of course, significant. So the implications of that study initially is that traditionally booster seat education focuses on guidelines. This is what you should do. This is what your child should be this high or this or weight this much in order to be put in this seat and put this seat in this way. But rarely you see booster seat education focusing on explaining people or parents why that is important. How is it that booster seats work or seatbelt work? So the implication of this study is that we need to start communicating not only what to do or telling people or parents giving instruction on what to do, but also why they do it. And one interesting finding is that one of the questions that parents were asked is to identify incorrect use or mistakes in the use of booster seats, and that it was another interesting finding that parents who receive the intervention were more likely to identify more mistakes, or meaning that they were more likely to understand what is the correct use. So not only understanding why is important to motivate people, but also ended up being important to understand how to correctly restrain a child in a booster seat. So what are the implications? Other implications, if we take this infographic, we can distribute online or modify it, of course. We can use it in car seat clinics, put it in pamphlets and brochures. Sometimes, in an ideal world, I imagine working towards mandating some type of label for car manufacturers in the same way that they have to put like a warning for airbags. I don't know. This is kind of the work that we need to start working in terms of policy development. So going back to the idea of boosting system one, the idea is that if we take this outside the realm of booster seats or car safety seats, we can just try to identify if there are other health stereotypes around. For example, concussions as a good candidate, that people have the tendency to believe that helmets prevent concussions when concussions are in fact more like your brain moving inside your skull and hitting the internal walls of the skull. So really, a helmet is not like going to reduce your concussion by much. So that could be a potential health stereotype. The idea of physical activity being sport related, for example, could be another health stereotype. Like people don't recognize that actually, if you use the stairs every day instead of taking the elevator, that's physical activity, right? And maybe that's why people don't engage, because I don't have time to go and get a bike and bike for 2 hours. So that's the idea behind health stereotypes. That's how I apply the notion of healthy stereotypes to the problem of booster seats. And also that's the idea of how we can use behavioral insights, in this particular case, to boost what we call system one, our instinctual, effortless, fast, and stereotype way of thinking, which pretty much is the one that we use every day, all the time, or most of the time. So yeah, that's, oh wow, 45 minutes. I hope, thank you for bearing with me. And I'm just leave the floor open for questions. I cannot see the chat, so I'm going to, with your permission, minimize this.
We now welcome any questions or comments. If you do have any, please, you can either unmute your audio line or you can type them in the chat box and I will ask them on your behalf.
Okay, now I can see the chat. Sorry, it's taking me that long. Okay.
Kitsiem Pipe, thank you very much for that presentation. Really enjoyed it. Just wondering, to your point about the infographic that you have developed,
yeah.
Have you pursued that option at all in terms of using it as part of the labeling and the materials that go with a booster seat sale?
No. I mean, when I mentioned the avenues, unfortunately, I haven't actively engaged, but yeah, with any group or association that we can do. But definitely, that's a great option too. Like, should go in those manuals as well. So if you want to, and if there is any contact that we can. Or you know anyone, or we can just pursue that avenue. Yeah, I will be happy to work on that. Yeah, but so far not. So far I haven't had the opportunity to work on this within the BC government because I joined this year. But yeah, definitely is an avenue that I would like to explore.
But I think there's a wonderful opportunity in the fact that the BC Automobile Association and the United Way partner to provide a huge number of car seats and booster seats to children throughout British Columbia. And we could develop the labeling. We have a strong partnership through the Community Against Preventable Injuries with those organizations. And it seems to me there's a fairly natural experiment there that could be also evaluated.
Yeah, absolutely. So we should, absolutely, we should totally recommend. Yeah. I'll get in touch with you, Ian, to talk about this because it'll be great. We could do that.
Great. Thank you again for your presentation. Loved it.
Any other questions?
There's one. Is there a white paper that covers this info that you could share?
Oh, sorry, can you repeat that? Yeah, my sound is kind of low.
No worries. It's is there a white paper that covers this info that you could share?
Oh yeah. So one is that we're going to share the presentation after this, but also one of the things that I've been considering is like making this infographic available to the public. So maybe we can just make it available through the BCIRPU resource section.
Yeah, for sure.
Yeah. So is there any specific, are they asking us our specific information or just the infographic or the presentation or anything else that, oh, okay, white paper. I see. Sorry. Yeah, just having issues with this chat. There is my dissertation, but yeah, I am working on publishing this paper. But yeah, I can totally share my dissertation, and it is available through the UBC website. Yeah, through the UBC website as well. Yeah, I'll send Anita the link so she can share it with all of you.
Yeah, and there's also a request for the infographic. If you could share that as well.
Yeah, absolutely. Yeah. So the infographic, I think now that now what I was looking at it is like, yeah, any change that you can make to make it even look even better and nicer, that's great, because so but as long as it preserves the intention and the content and the notion of communicating why seatbelts, how seatbelts work, yeah, and why booster seats are important.
There's the next question is, do you think that similar approach would work? Example for environmental public health. Any suggestions? Great presentation, thank you.
I'm not really sure what environmental public health, what do you mean about environmental public health, like in terms of, for example, like a pollution. There's a lot of research on this type of behavioral insights or interventions for that type of environments. So if you're talking about environment as in overarching policies around, for example, food labels, yeah. There's actually a lot of research on that. Germany, for example, there's a behavioral insights unit that work with the German government in changing the nutrition tables in food and putting more like a traffic light system. Because again, sometimes when you tell people, oh, these cookies have this many grams of salt per cookie, like, I don't know, 12 grams of salt per cookie or 5 grams of sugar per cookie, that doesn't really mean much unless you understand how much that is in relation to what you need to eat per day. Then that will tap into system one type behavior, right? So in Germany, they implemented this traffic light system, and it actually seems to be pretty effective. Yeah. Jennifer, that's a great question. Because for nudging interventions, typically, yeah, as I mentioned, you need what is called a touch point, something that an individual interacts with, and ideally that should be closer to the moment of decision. So I'm going to connect Ian's comment about preventable, the community against preventable injuries. So for example, you can try to be creative and look for a touch point. So in the community against preventable injuries, a few years ago, they put towels on the beach during summer with the message, you're not expecting to drown today. So that'll be a touch point, right? But in general, in health, is really hard. It's really hard to find a touch point that you can use. So the reason I use a boosting approach to this is because of that limitation of nudges. So yeah, that is a really good question, and thank you. So yeah, sometimes you can, but sometimes in public health specifically, I will go for boosting in many cases. The barriers to booster, now I'm being able to read the chat, so thank you. So the barriers to boosters come up during my research. But yeah, of course, in terms of while reviewing the literature, of course, barrier to using boosters is an important element. I was focusing mostly on this idea of the stereotypes. So I was trying to work on that stereotype. But definitely that doesn't mean there are no barriers, right? So for example, if you go to a First Nation community, they often travel with a lot of people because they give rides to each other, right? So they carpool a lot. So there's no room for a booster seat, right? So if there are 5 people in a car, so that will be a barrier that is important to address, in addition to explaining why booster seats are important and how they work. Then, yeah, there might be other types of barriers, like the child is resisting the use of booster seats. So again, my research doesn't ignore or negate that. Is an additional piece of information to kind of create that, to motivate or encourage parents to use booster seats. So, and if I didn't answer appropriately any of the questions, please let me know and I'll complete that.
And there's just 2 general comments. Yeah. One is, I appreciate the information and agree with the needed safety, although there are many regulations and guidelines that people need to follow. It surprises me how the RCMP and other lawful programs don't follow through with fines, etc., such as people not wearing helmets. And then the second comment is just, thank you, great presentation. And the research you used to supporting this presentation would be great. So again, we will circulate those resources and we will circulate.
Yeah, absolutely. Yeah. The thing with specifically booster seats in terms of fines is that at least in British Columbia, as far as I remember, is secondary enforcement, right? So a police officer cannot stop you for the booster seat, has to have another reason. So that might be it. But yeah, I agree. Like, I see a lot of people not wearing a helmet and not getting fined even when they ride without it in front of police officers. So enforcement, again, that goes back to the 3 E's, right? Education, enforcement, and engineering. So this is more like the education portion of the 3 E's.
So thank you once again, Dr. Ishikawa, for your presentation. Very, very insightful. And we look forward to, if you have any questions, again, all of you have my email, I can direct them to TAC. And we look forward to seeing you next time.
Okay, so one final thing. Probably too late, but anyway. No, that's it. Too late. Okay, thank you very much.